And I have the pleasure of introducing our speakers this morning. So we have, as I've been listening to a lot of the discussions this week, particularly on the physician revenue cycle panel and my panel, which is the best panel, famously, we have heard a lot of thoughts on coding and claim scrubbing, as well as just a lot of the changes that are happening in our industry from a claims and revenue integrity perspective. And so I think you'll find this is a really timely discussion. This morning we have Stuart Newsome, who works with me at Alpha 2, and he is our Vice President of Strategic Partnerships. He has over 26 years with Alpha 2 and in healthcare, and a lot of expertise on the coding side of things, and I always go to him when I have questions because he really knows his stuff. We also have Kathy Pride, who's the Executive Vice President of Coding and Documentation Services at Panacea Healthcare Solutions, who's one of our customers. Incidentally, she also has 26 years of healthcare experience, so that was a really nice thing we discovered this morning, is 26 is our lucky number. And you know, she really just brings a lot of expertise on the coding and documentation side as well. And one of the things that I'm really interested to hear from them is how we really look at the entirety of the revenue cycle for making sure we're preventing denials, making sure we're really understanding how all the things flow within our different systems. I know everybody's going through a system conversion these days. And so I think this will be really timely for y'all, and I hope you enjoy their talk. So welcome, Stuart and Kathy.
Thank you.
All right, thank you very much. Hey, good morning, everyone. Can everyone hear me? Is this microphone working, or are we just...
Hello, hello.
Quiet?
Be
Hello?
here all week.
Yeah, I'll be here all week, exactly. Well, I'll speak a little louder because I can speak loud, as Carrie can attest. So I'm just very proud to be here, very thankful for everyone inviting us, and thank you for showing up for breakfast. So, and I'm really excited to be here, not only for you guys, but also with my dear friend Kathy Pride. I've known her for a very long time. We're dear friends, and anytime I can speak with her, it's always a blessing. So thank you for being here, Kathy. So definitely. So something that's very near and dear to my heart is talking about the continuity of throughout the revenue cycle. And I want to kind of talk about that today and what I mean about that. And essentially, if we can move to the next slide and then the next slide, because this slide's about us, and it's not about us, it's about what we want to share with you guys. But we want to kind of talk about a quote we had from one of our clients who really put it very well. And I won't quote it verbatim because it's in the slide deck there. But basically, you know, what he was referring to was that we're really conditioned in this world to look at denials management and the revenue cycle in a manner that we're all kind of accustomed to following. You know, we're kind of following in line to what that revenue cycle management process looks like. You know, the claim goes out, we get a denial back, and we're expected to go ahead and look at that denials and correct it on the back end, being more of a reactive approach. And you know, I really appreciate his quote from the standpoint that how can we do these things differently? And it kind of made us think internally as a company, and I know Kathy, with her experience in an auditing world, has seen this as well, is what can we do differently? And so we kind of put our heads together and kind of thought, okay, what are some of the things that we can share with others on how we can just break the mold of what we've come to say, this is our expectations, and really is our expectations, the traditional denials management that we're working on today. So when I talk about knowing the continuity or what that continuity is or achieving that continuity, I'm really talking about revenue integrity, okay? So basically revenue integrity comes down to, and all of you in this room probably realize this, is it something that you're actually practicing?
There we go.
Thank you. Let's see if I can get this right. So is it something that we're actually accomplishing each and every day? But it's really basically teamwork. It all comes down to everyone in the practice or in the facility or in the organization going hand in hand, making sure that you're accomplishing all of your goals from the beginning to the end. It all starts with the patient, starts with the patient encounter. Some of the things that you want to work on obviously are, and I'll just advance this forward here, is, you know, you want to make sure that you're accomplishing all of these bullet points that I'm looking at here, and it's basically making sure that end to end, from the beginning to the end, that you're making, you want to make sure that all the data is correct, all the coding is correct, the patient intake is correct, that the single goal is to make sure you're handling the AR, is everyone on the same page. Because everybody on the team doesn't really follow along with that, doesn't necessarily make sure that they're only focused on what their job for that day is. And do they really have the patient in mind? Do they really have the overall claim in mind? Do they have the reimbursement goals at the end in mind, so to speak? So one of the things that I wanted to kind of go over here is what are those obstacles that we come over with revenue cycle management? And so I just want to kind of turn it over to Kathy and kind of talk about, what are these obstacles?
Well, a lot of the obstacles that I've encountered in my career, and just working with other organizations now in a consulting role, is the lack of communication sometimes between departments. That they're very focused on what they do, and they don't truly understand what the other department is doing. They have a high level of understanding of it, and then sometimes it's just a lack of cooperation. One I always find the squeaky wheel is the one that gets their way, whether they're the right one or not. They're correct. They're the squeakiest wheel. I mean, that's been kind of my experience, and I'm working with a client in Florida where they're billing something out incorrectly. And the revenue cycle manager and the HIM manager are fighting about it, as to what is how they want to do it. And so, it's just kind of that lack of cooperation sometimes, and then the lack of knowledge and expertise. I know that there's a shortage right now of employees, so we're hiring people who are less experienced. Are we giving them the opportunities to expand their knowledge? Are we teaching them? Are we paying for them to take classes? I know back in the early part of my career, I had to pay for all my own stuff because I barely got books. I had to go buy my own coding books, so there, and I find that a lot of times with coders now, I hear that often, is that they get an encoder, but if they want a book, they have to go buy their own book. It's like you can't be a carpenter without a hammer. You can't be a coder without coding books. So I feel for them, because not a lot of times they don't have the financial means to actually go out and buy their own. Or maybe they get their books, but their employer doesn't pay for them to attend conferences, or to learn something new, or webinars. Nowadays, everything is virtual, so it's a lot easier for people to join, but it still costs money. I know the average price of a webinar out there is between $150 and $200, and to a single mom coder, that's a lot of money. So just trying to get them their knowledge, increase their knowledge. Nobody wants to be stuck in the same job, too, for the rest of their life. You're always wanting to learn and move up. I think the ladies from, was it Emory yesterday, that were here talking about the physician cycle, I thought that they did a good job of trying, and there was another gentleman here, his name was, I think is Al or Alan, but he was talking about the lack of employees and trying to get that upward mobility education within their organization, which I think is admirable, So I find that, sorry, I don't have this, I can't see the screen, so I'm looking at my phone here on the bullet points here. Incumbent processes and technology. Sometimes it's the lack of technology, and sometimes the technology is just behind what we need to do. And I think keeping up with the latest technology and being able to change your processes on the fly, we have to, things in healthcare are always evolving. Sometimes I feel like I'm almost a dinosaur at times, but always having to keep up with the newest and most current stuff there. So those are a lot of the obstacles I've found in the continuity.
Right, exactly. And I think that I would agree with you that some of the incumbent processes and what we mean by that is we've always done it this way.
That's how we've always done it.
Right.
Yes, that's what I hear a lot.
So it's always like, and this is how I was trained, and there's no, kind of being, thinking on the edge and how can we do things differently, always asking those questions. Is there a better way? And there is a better way. There's always a better way. And you always want to investigate how those things occur. And then from the technology standpoint, are you taking advantage of the latest technologies? How old is your systems? How old is your processes? And you always want to make sure that you're on the cutting edge of what's new out there. Some of the vendors here today, some of the vendors that you may see at some of the trade shows and whatnot, it's always worth investigating and seeing what's out there that can help you with your processes as a whole.
And being more efficient as well. I think trying to do more with less people is kind of the name of the game these days. Right,
especially these days. So I'm sure, just impromptu, just show of hands, how many of you seen a reduction in staff over the last year or just during this COVID-19 epidemic? Yeah, just almost everyone. So it's a challenge. It's a challenge to make sure that we can do more with less. And how you can do more with less can be analyzing all these obstacles, especially the incumbent processes, as well as the technology that you're overlooking.
Are a lot of people having to outsource, maybe coding jobs and billing jobs, having to outsource those because you can't find enough people? So, that's another obstacle there is not having enough people. And then outsourcing, that comes with challenges as well. Are they doing a good job? Or is somebody, auditing what they do, checking up to make sure they're doing it properly, compliantly? I'm in the compliance world, so I'm always looking at compliance.
Right, exactly. So one of the things you also can do is, how do you measure your success? How do you measure, for instance, one of the processes that we look at Alpha 2 is, what are the outcomes? How can we improve that revenue integrity? Some of the things I was talking about earlier is, how can we affect, that bottom line? And one of the things we quickly looked at is what are some of the statistics that people look at that measures that success. And one thing that comes up is the first pass claims rate. How many use first pass claim rate as their measure of, yes, this is how we're getting through to the clearinghouses, to the payers, and this is our measure of success? All right, no hands, that's great.
Yeah.
That's really great.
I have a really good friend that took over practice administrative of a fairly good-sized orthopedic practice. And when she came in the door, they said, oh, yeah, our 98%, we're 98% accurate on our claims. And she started digging into their AR, and she's thinking, well, you have a lot of stuff in your AR. How are you at 98%? Well, the previous practice administrator had convinced them that their first-time pass rate was their accuracy rate. So they had no clue, this group of physicians, and I've been in the physician world. That's kind of where I live and work. But, I love physicians, but they're not really always good business people. So sometimes you have to, hold their hand and explain to them what a first pass rate means. Is it just went out the door. It doesn't mean it got paid.
Right.
That's all it means.
Right.
And I think at the discussion yesterday, they were talking about that, and even your denial rate doesn't necessarily mean you did anything wrong. They were talking yesterday about the insurance companies just holding claims for really no reason at all, just because they can.
Yeah, because they want to.
Just because they can.
Yes, exactly.
Which is scary, isn't it?
But first pass claim rates really become the industry standard, so to speak, for some reason, as to this is the success of the claim. As Kathy said, I've seen 97, 98, 99%. A lot of people really say, okay, we're successful. But a lot of it doesn't really correlate to what exactly equals denials. So if your first pass claim rate, let's say, is 98, 99%, then why on an industry average is 1 out of every 5 claims denied or rejected? And they're not really looking at things as if there's underpayments, some of those line item denials and line item rejections. So it's very important to kind of take a look at that from the standpoint of, okay, well, let's take a step back and look at what is that first pass claim rate. And I like to use the analogy that I know you probably won't believe this, and to look at me, you're probably like, no way, but I used to be a bouncer back in the day. And yeah, kind of like a Patrick Swayze moment, right? But I can remember getting into where I worked, you had to have, there was a dress code. And if you dressed the right way, you got in, right? First pass claim rate's the same way. You kind of get in. But your behavior may get you thrown out, all right? So many times we threw a lot of people out because of their behavior. Same way with a claim. First pass claim rate is the person at the door who's making sure you're in appropriately, that everything looks right, you're acceptable from a... But then once you're in the door, there may be some other factors that may get the claim denied. So that's why there's not really a good correlation between what is a first pass claim rate and what exactly is denials and rejections. And when you equate that, you look at this, okay, well, 1 in 5 claims are denied or rejected. You can have, that basically means that 15 to 20% of your claims are typically denied, right? So the math doesn't really add up to me when you look at it from that standpoint. And when you look at the statistics also, that of those 15 to 20% that are denied, that 60% are typically never gone after. That most practices don't go after all of them. They just basically go out and try and recover about 60% of them, because a lot of factors play into that, like workload, personnel, do they have the bandwidth pretty much to take care of that information. And so as a subsequent byproduct of that means that 18% of those 15 to 20% is never ever recovered from a denial standpoint. So when you look at first pass claim rate, it's kind of a misinformation or almost a false positive, if you will. You really kind of need to look at your denials management. I know everyone in this room kind of has great denials management processes, but it's just very important to be sure that you kind of rethink those processes from a proactive perspective instead of a reactive perspective. Because as I said, again, we've kind of been conditioned, hey, this is the way it's supposed to work. We send the claim out, claim comes back, we're supposed to rework that claim, okay? So when you're looking at reworking the claim, typically, and everyone's kind of heard this stat, the stat's kind of old, but I think it could be a little higher these days, but typically it's about $25 to rework a particular claim. And this is a stat that I really stress everyone should know within their organization. How much is your cost to rework a claim? And this is a national average, and I'm surprisingly find that many organizations don't even know that number. That's a very crucial number to understand, because it can help you realize and wake up to how much money you're really spending going after the revenue that you should have gotten in the first place. So from that standpoint, we just kind of want to talk about kind of what the workflow looks like. And this is when I talk about continuity throughout the revenue cycle management process. And you kind of want to take a step back and look at, okay, well, you consider end to end. And most people, when they talk about denials management and they talk about claims, they talk about back-end administrative. And even the physicians, and Kathy can probably attest to this as well, they go, oh, that's all back-end stuff. I don't deal with claims. You know, I just see patients. I want to take care of patients. But it really starts at that front end for those processes.
The minute the patient walks in the door.
Exactly, exactly. So you really kind of want to look, as we look through this workflow, we look through this chart here, I just want everyone to pay attention to the fact that there's many different areas within your organization that claim is being touched. And if you can take care of things and issues ahead of time, whether it be at the patient encounter, whether it be at charge entry, whether it be at submitting the encounter, processing the claim, and yes, even at the clearinghouse level, then you can reduce your denials. We're not really saying that you can totally get away from all of your denials, because denials are never going to go away entirely. But you can significantly reduce the amount of money that you're spending on denials on the back end would be essentially key.
Did you have a question?
Yeah, I do. Hopefully everybody can hear me. So I was actually talking with someone at dinner about this last night, essentially. On the front end, right from the patient access point, right, where they're getting the demographics, they're entering the insurance.
Yes, very important.
Very important, right? Because a lot of denials result from just incorrect information entered into the system. So one of the things we were talking about is when will, and some providers are getting on board with this, but
You're a girl after my own heart.
I
I've been
know.
saying that for years, honestly. It's, I mean, even when I started in coding, it was so early. It was in the, I think it was 92 when I took my first class in coding. And it was kind of a new thing. And then as time went on, things got more and more complex. And I used to tell the doctors, I said, if you're going to Taco Bell to recruit for your employees, you're going to get what you get, you know? You need to find people with experience. And if you can't find people with experience, at least go to the colleges and find the tech schools and find people who at least have a basic understanding, who've taken an anatomy and physiology class, who've taken a medical terminology class, you know, so that they're not walking in the door completely like, you know. How many times have you hired somebody that has been amazing, you know, with little experience, but they had a basic understanding, and then you hire somebody, you know, that they're just, cut them quick. I had a boss that used to say, hire them fast, fire them fast, you know. If they're not going to work out, don't spend a year trying to make them work out. You usually know within 90 days if somebody's going to be good. But getting those people right up front, you know, who can actually enter in a patient ID number with insurance ID number without a typo. You know, it sounds so simple, but that's where a lot of denials come back from an insurance ID number incorrectly entered, you know, into the system with a typo. I was thinking, you know, I was just sitting here thinking about this, that nowadays I enter my own information. There's patient portals. What if I make a mistake? Is anybody checking that? When I come in and they actually ask me for my insurance card, are they comparing it to what was in the system that I entered in that I might have made a typo on?
Exactly.
So-
Exactly.
Yeah.
And with this kiosk, that is a very important fact. You know, you have, you know, think about your patient population coming in. You know, are you really trusting them to enter their own data? It's a good idea, right? They can enter their own data, but are you really trusting that data to be accurate? Because it's your reimbursement that depends on that. And, you know, Kathy brings up a good point about, you know, you're hiring personnel, and one thing she mentioned was medical terminology. Have they really understood the medical terminology and how the physician thinks and sees a patient and how they document things and that coding? Because I always tell everyone, you know, codes are the language that insurance companies understand what's going on in that practice, what's going on with that patient encounter. And if the coding's wrong, it's all out of whack.
You know, even before the coding, you have the documentation by the provider, and I read a lot of documentation in my role. And, you know, I see things, I'm like thinking to myself, really? So, I mean, there was one the other day, a patient had, I believe it was leg pain, but the exam it was a full exam, including a genital urinary exam. Like, okay, they came in with ankle pain, and you looked in their eyes and their ears, and you did a complete, comprehensive, every organ system exam. I doubt it. You know, they're using a template, right? They're pushing a button, and it puts this template, and they're supposed to go in and correct that template for any positives or things that they didn't actually do. But they're not doing that 100% of the time. There's some physicians that are better than others. So now, if my documentation is incorrect, guess what? My coding is going to be incorrect as well. And then I'm going to bill out a level 5 visit and with a ankle pain diagnosis code, and guess what the insurance company is going to do? They're either going to deny it or downcode it. And they're doing that a lot, especially in the ED right now. I don't know. I've been on United Healthcare. They have a ED analyzer, they call it. I believe that's what it's called, ED analyzer. And you put in the diagnosis codes and any things that were done, diagnostic studies that were done, and it comes up with a code. It has nothing to do with the exam, medical decision-making, history of present illness, nothing to do with that. And that's how they're coming up with codes nowadays, and that's how they're downcoding you. So it's a proprietary, as they call it, it has a proprietary algorithm in it. So, you know. I mean, I actually working with 2 different clients right now in 2 different parts of the country who are seeing a lot of denials or downcodes from their ED visits. And they say, and we did an audit for them, and they are coding based on the AMA CPT guidelines, but they're still getting downcoded based on medical necessity. So that's something that our doctors a lot of times haven't been educated in documenting medical necessity. We teach them how to do those, I need 4 elements of the HPI, I need, a complete review of systems, I need at least 10 of these reviews, but we forget to teach them about medical necessity, what's actually medically necessary for that patient, and maybe they're not a level 5, maybe they really are a level 3, but you shouldn't be over-documenting just to get to that level of service. That's actually in the Medicare Carrier's Manual says, the volume of documentation is not the main criteria for selecting a level of service. It's medical necessity. But that's a really hard thing to teach a physician, is how to document medical necessity. So, but that's documentation at that point of care. How many times have you gone to the doctor and they billed you, you were there for maybe 5-10 minutes, and you got your bill and your office visit is $350, and you're thinking, so I said, what code did you charge me? You get a 99204 or a 99205, and all I did was come in there with knee pain. It's like, how did you get to a comprehensive history and a comprehensive exam when all I did was come in with knee pain, right? Like, maybe get the history, because you did make me fill out a 4-page questionnaire about every ailment I ever had in my life. But, but I didn't, it was a knee exam. That was it. How do you get to a level 4? It's, and so I tell the doctors when I go in now that I'm a coder so that they know up front, don't do that to me. Because
Exactly.
I will come back and fight you. So,
Right. And medical necessity still is the overarching criteria,
yeah.
as I quote the Federal Register.
It
Yeah.
is in the Federal Register, and guess what? That makes it law, too,
Right.
by the way.
Right.
So it's not a guideline. It's a law.
Exactly.
So,
So some of the things that we want to go over is some of the suggestions, and I'm going to really lean on Kathy heavily
okay, well, I gotta get,
for
I can't
this.
see behind me, so I have to pull the slide up in front of me here. That's what I'm doing on my phone, by the
So
way.
we're going to kind of talk through some of the suggested actions that practices and facilities and organizations can take when they're looking at this. And so from a standpoint of appointment and scheduling, and you kind of break this down, we got it broken down into 5 categories, but you'll find and see, a lot of this stuff overlaps. A lot of stuff can be done later on, early on. But my whole message is the earlier, the better. The earlier you can get this stuff taken care of, you don't have to fix it later. I'm of the mindset that if you can touch it once, that's the most efficient way of handling things. If you have to touch it more than once, then you're wasting time and money. So with scheduling, yeah, go ahead, Kathy.
Well, I think the verified insurance coverage, we talked about that already. So that's another important one. I wanted to kind of skip to the pre-authorization. So I work with a lot of surgical practices, and the provider or the physician, they get a pre-authorization for what they think they're going to do. But when they open the patient up, what they actually perform may be different, or it may have an additional procedure, and that one wasn't pre-authorized. So it's really good to work with have your pre-authorization or your surgery scheduler or someone working with that physician and say, what all could you do? I know when I fill out a consent form, they list a whole bunch of stuff that, they may or may not do, right? So get a pre-authorization for all of those things, all of them, because I've seen, and it's happening more and more, because insurance will try to find a way to not pay you. That, well, we didn't pre-authorize that code. We only pre-authorized this code, right? And it's a digit different because, I don't know, I can't think of an example off the top of my head, but because of one additional thing that was done during that, and sometimes they deny the whole thing, even though they authorized one code, you did that one code, but you had to do something else while you were in there. So it's really, really important to have a coding person with coding knowledge and the physician say, what all could you do? And I know in smaller practices it works, because the doctors really spend a lot more time because they know that's their bread and butter, that's their money. And but when you have employed physicians, it's a little harder because it doesn't affect their pocketbook unless their RVUs are affected, or sometimes they bill those RVUs even if they didn't get paid for them, they still get to collect their money, their paycheck on it. So that's another thing too, is this physician compensations, billing on paying physicians based on their RVUs. Are you actually getting paid for all those RVUs that they're billing, right? So that's a whole nother thing. But yeah, the next one on there is updating your fee amounts. Right now, that with the price transparency, that's even, if you're a large healthcare system and you employ the physicians, you have to start, display your fees now. And if you're not, they're going up on the penalties next year. And it's going to be very expensive.
Yeah, and to me, that's kind of like the kind of low-hanging fruit. I'm always surprised at one of the things that can be proactive and corrected easily is updating the fee schedules. Many practices, I mean, you'd be astonished at large organizations that we go in and find they just haven't updated their fee schedules, and that's part of the problem. And some of the things that we look at with our solutions is the fee appropriate, particularly with Medicare. And when we look at that information, we're like, well, when's the last time you updated your fee schedules? And everybody kind of looks at each other like a deer in headlights. What's a fee schedule? I'm like, okay,
Well,
you may have a problem there.
And a lot of people base their fees off of Medicare, what Medicare pays, and maybe they'll do Medicare plus 50% or 100% or something like that. But you may have contracts out there that pay more than that. So you make sure that you're looking at your contracts as well when you're setting your fees.
Exactly.
Because they're going to pay you the lesser of, right? If you charge $100 and they'll pay $120, I saw that a lot with preventive care because Medicare doesn't have preventive care services. They don't pay for like an actual preventive care exam. They have services, I know, but like the preventive care annual visit. So like for pediatricians and primary care doctors, they'll set those fees kind of low, basing it like on a level 4 or something like that. And then you'll find out that the insurance company will pay $150 for something like that, and I'm only charging $125. So make sure you know what your insurance companies are paying.
Mm-hmm.
So.
Exactly.
All right.
And that last point is that
Patient estimation amounts.
Patient estimation amounts. That's really kind of a new thing. It's not so new, but it's really kind of taken away where you kind of know what the patient is expected to have, and then to collect that information up front, present them in a manner that they can to be acceptable and not infringing on.
Yeah, we have a new law called surprise billing.
Yeah, surprise billing.
Right? Surprise!
Yeah.
Oh, that doctor, your anesthesiologist wasn't on your plan, but everybody else was. I actually had that happen to me. You know what? I never got a bill for it either.
Hey, bingo.
I won't say which hospital it was, but
Yep.
never got a bill.
Exactly. So that next category, what are some of the suggestions you have there, Kathy?
Well, I talked a little bit about medical necessity. I think that's really your clinical documentation improvement, working with the physicians, explaining to them, don't just tell me what you did, tell me why you did it. Mm-hmm. That's medical necessity, is the why you did it. Sometimes a lot of doctors are really good about it when they're documenting their op reports and things like that, but it's the E&M visits is where they tend to, the chief complaint and the history of present illness is where you get a lot of that medical necessity, as well as the assessment and plan. So if you really, the patient had a twisted ankle and you did a heart, lungs, and ENT exam, tell me what the medical necessity of that was. There may have been a reason that you didn't spell out for me here,
right?
In this note. Maybe the patient fell and hit their head, and that's why, but if you don't tell me that, what's the medical necessity for doing that? So. Right,
and one of the things with the E&M, everyone's very well aware, hopefully by now, with the 2021 guideline changes that came out, and they really, in an effort to release the burden of documentation for physicians.
And it really did, but they're still doing it. They're still documenting all that stuff we don't need anymore. And I will tell you, if you're the AMA is planning on rolling it out to all the other E&M categories, ED, home visits, skilled nursing, inpatient, all the pro fee. They're going to be rolling it out, they said, in 2023. So I'm expecting to see something on that. They said they're going to be similar to the office visits, but they will not all be exactly the same.
Right.
So I've been trying to attend as many of those meetings, AMA meetings, as I can. And so their symposium is in November, so I'm hoping that they're going to give us some kind of insight because it's going to take, like, the ED physicians and hospitalists, folks that didn't really have to deal with those new guidelines, haven't been educated on those new guidelines yet. So I'm hoping they'll give us some kind of insight, like they did with the office visits, giving us the guidelines a year in advance, so that we could start training our providers. So.
And we kind of skipped back the importance of an ABN, and hopefully everyone understands what an ABN is, Advanced Beneficiary Notice, and where that falls in the workflow. This is something that's very key that I find that is revenue left on the table, because, with Advanced Beneficiary Notices, specifically with Medicare, if you don't have that waiver signed by the patient, you cannot go back and bill the patient. And there's a lot of revenue left on the table when they don't have that ABN. So and this goes back to technology, workflow processes. Do you have a solution that will actually generate an ABN form if there's no or lack of medical necessity? Maybe it doesn't go with the policy, and you need to have that waiver signed by the patient. If you're doing it on the back end, it's too late. It's too late to know that, even if you had a good claims editing solution. And it goes, oh, should have had an ABN, it's medical necessity. Well, if you don't have the ABN, it's really, you can't go back and bill that patient. So it's very crucial that you go ahead and have those processes on the front end to make sure you're checking for that going forward. And then the last point in this section, do you have any viewpoints on that?
What's it? Edits for the encounter?
Yep, edits for the encounter. I guess. And it kind of speaks to the fact that, most people think, oh, editing happens on the back end. So how important would be editing at the point of encounter be? Is that beneficial for the doctor? Because most doctors are like, oh, I don't want to code.
Well, in an office setting, I find that most of the times the physician is selecting the code. So anything that's done in an office or a clinic setting, they're doing their own coding. So having edits in place so that they know that this is bundled with this, so you can't charge both of these things, or giving them the correct codes, things like that are really beneficial, whether they'll actually use them, see them, or understand
Right.
what the edit is, especially bundling edits. They're like, well, I did both of those things. And trying to explain to a provider or physician what bundling means is that you're already getting paid for it in the primary procedure, that it's, yes, we know you did both of those things, but it's included in the primary procedure. You can only bill for it if that's the only thing you did was the
Right.
bundled procedure. So they don't quite understand that. And it's a concept that is, some reason is, very intelligent people. You have to be really smart to be a doctor, but for some reason they can't get that concept about bundling. I don't know why.
Correct.
I know you're smarter than that, doc.
Exactly, and they're just not used to doing it. And it's one of those things that you have to say, okay, look, if you can, because they're the ones that understand what's going on with the patient. So they're the ones that understand, okay, how can we communicate this to the carrier rather than documentation, which Kathy's already alluded to how important that is, and you'll see that as another point going forward here.
Yeah, we're getting close on time, so
going
to the coding and the pre-claim again. That's my sweet spot. There is coding, and I'm a proponent of coders doing coding and letting doctors see patients, but I get that sometimes if they're seeing 20, 30 patients a day, that a coder may not be able, it might be cost prohibitive to hire coders to do all of the coding. But a really good coder on an E&M, especially with these the new guidelines, can really code pretty fast. You're just looking at specific things within that medical record, and you can scan that medical record and code pretty accurately, pretty quickly. So one coder, you don't need one coder per physician. You could have maybe one coder per every 3 or 4 physicians, depending on their volume of work. And especially surgeons, they're seeing a lot of post-op patients. That's something very simple to code. You just want to make sure that there's possibly seeing the patient for something other than the post-op visit, and that's an additional charge, right? So you can code something in addition. And that's why coders aren't cheap. That's because they're worth their weight in gold, and I like to think I am too, but well, come on, that was funny.
Right, that was funny.
but yeah, having doctors really, there's a few out there. I've met a few in my lifetime that actually like to do the coding piece of it, but most of them don't. They don't like to. It's a burden for them. And so if you have a way where you can have coders, doing the coding, at least validating what they already put in, maybe, because I know a lot of times the medical, you can't close out an encounter without a code there, so that for them to move on. So let them put a code in there and then go in and validate them before the claim goes out. That's what we do that for a couple of clients. We have people and we go in and they're small, they can't afford, they're in rural areas, and so it's not that they can't afford, they can't find coders. And so, there's a lot of coding companies out there that do that type of work.
Right, exactly.
Some better than others.
Exactly. And of course, documentation is key. One of the last points here, you saw it in the previous column. Documentation really is key. If it's not written down, then it didn't happen, even if it did happen. So most auditors, and I think Kathy can attest to this, how much documentation is just lacking still to this day. And with my 26 years experience, my first year I heard that was an issue, and in my 26th year, it's still an issue. If
you're not auditing your claims on a regular basis, at least annually, then you're probably missing something. You're either overcoding, undercoding, or you're missing something, because nobody's perfect and nobody does it right every 100% of the time. So, and if you're have internal auditors, once in a while, maybe every few years, you should have an external auditing group come in and take a look at your charts and just make sure. And having that feedback between the coder and the provider, the physician. I believe yesterday that came up, and one of the, I think it was Emory that was up here. Was that correct? They had pods where they have groups of people, and they have one-on-one relationships with the providers and with the physicians, and so that they get that real-time feedback from that coder. I think that's excellent. I thought it was a great work model that they had. So.
Excellent. So now with the billing, this is kind of where we're in the wheelhouse of where everyone thinks this is all supposed to be happening, and it still is. We're not necessarily saying, move a lot of these processes earlier in the workflow and forsake on the back end, because it's very much needed that even though you're checking all these things at the patient encounter, at charge entry, you're also checking it at the coding with the charge capture information. But you still need to have adequate processes, and even with organizations that don't have those processes early on, we see a lot of lacking, a lot of room for improvement even at that level.
Yeah, I want to bring out the one about edits for claims. That there's a lot of, like you have ClaimStaker, there's a lot of software out there that edits these claims. But if your biller is not educated properly on what those edits mean, sometimes they still go out the door that way. My company has software, auditing software, and we find we have a rules engine where we'll run claims that have already gone out the door. These are not pre-bill. And we find add-on codes with no parent code. We find mistakes that a claim scrubber would have caught. But so somebody is sending those on out the door, even though the claim scrubber is catching that as an edit, right? So it's like, okay, you have all the edits in place, you have everything in place, but yet you're still having claims go out with mistakes on them.
Right, exactly. So it's amazing, and it kind of goes back to that first pass claim rate. Oh, we're at 98%, we're great, but then you have 10, 5%. Even 5% denial rate is great by the industry standards, but really 5%, can we do a little bit better?
Yeah, how much money is that
right,
5% actually adding up to?
Right, exactly. And the cost for reworking that claim, what does that entail? So that kind of goes hand in hand with the last section here with denials management. I'm sure everyone in this room has a great denials management process. And I'm sure everyone is on top of their game regarding that. But still, you may want to kind of take a look at those denials managements and what are you looking at from a standpoint of the 835s, those CARCs and RARCs. I know that's kind of a bad word because CARCs and RARCs seem to be very vague and nebulous. You're like, what exactly does that mean? And with HIPAA and the standards they made, it really made it legal for at least every insurance company to use the same codes. but they can still define what those codes mean individually. Has anyone found that? You kind of like, okay, wasn't it supposed to be standardized? Well, yeah, they're using the same codes for those carts and RARCs, but yet you'll look across the board and the definitions for those carts and RARCs are very, very different. Yes.
So an example, so I'm manager of denials and prevention at St. Joseph Candlers. This is my nerdy wheelhouse here. But, you know, we redefined Part 39, which is a research denial. Really, it's a net necessity denial. It didn't need something up front. So, you know, we use this equate for data analytics. And so, you know, I have a dashboard built for all that to come through every day, real time, that are actually loads at 7, 6:30, 7 o'clock. So that's a good example.
Yeah. Yeah, it's just very crucial to kind of relook at those processes. You know, early on we talked about the necessity of looking at fee schedules, and you think that's like a duh moment, you know, right? Yeah, we're going to look at fee schedules. Same thing with your carts and RARCs. Make sure that and it's also communication and cooperation. So all this that we've been talking about kind of plays in hand, where you got to make sure everyone's on the same page, everyone has that continuity, so to speak, of the data that they're looking at. Because if the carts and RARCs don't match up with what you're trying to do in the front end, how can you take those codes, those reason codes, those denial codes, and then translate it to, okay, well, let's don't do that anymore. Okay, so if your denials management process is just, okay, we're just going to correct and refile, well, what are you doing to make sure that translates earlier on to do preventative action? Because if it's almost like wash and repeat. You know, you're just going to repeat the problem.
It's one thing to look at all the reasons why, but if you're not doing anything corrective action, then you're the hamster in the wheel, right?
Right.
Just keep going, keep on going. You're surprised at how many times I see that. You know, the companies hire us to come in and do their auditing, and we give them our recommendations, and then you go back a year or two later, and they hadn't implemented one thing. And you're thinking, wow, you know, you spent all that money, and then you just did nothing. It's amazing.
Right. You can lead a horse to water. Is that right? The saying that goes, right? Right, exactly. And then the appeals process. Obviously, there's legitimate reasons why you feel this claim should have been paid. You know, it's one thing to rework a denial, correct it, resubmit it so you can get paid, but you also need to go through the appeals process, and it's there for a reason. And most carriers will pay based on historical information. So if they're denying things and no one speaks up and says, hey, this should be paid, they're going to probably keep on denying it. But the more you stomp your foot and say that this needs to be paid, that's what that appeals process is all about. So I would definitely, more important than your denials management process is your appeals process, because, you know, stand up for yourself and make sure that it can be.
Yeah, and that's where your documentation comes into play. Mm-hmm. When you get a denial and you think, oh, well, we can fight this, and you go back and you pull the documentation and you're just like, oh, no way, they're not going to pay this. Forget it. I'm not even, you know, and that's on the physician, right? That's their, so getting them to correct their behavior. You know, if you would just document this, we need you to document. You say you're doing it, but where does it say it here in this medical record? You know,
right?
So.
Right, exactly. So with that, I mean, we can open it up with questions. We've had a few questions already, but definitely want to hear from you guys while we're thinking about some of the questions you may want to ask. I do want to put in a plug for Alpha 2 here. We have the Alpha 2 University, and Kathy mentioned the importance of coders. That we have CEU programs with Alpha 2 University where you can listen to a lot of our webinars and whatnot, and your coders can get continuing education units from AAPC. And those webinars really are given mainly by myself and Stacy Licati, who's awesome. Your very own Carrie Bennett has been a part of that process where she's done some great webinars. And so we give webinars that we want to be informative and productive and really be impactful for everyone. And it just so happens that we also can give some CEUs for those. So just check us out on our website. They're all on demand. It will cost you an email in your name and probably some junk email from that. No, none of our emails junk, right? But yes, so it will cost you some information, but you can look at all of our information. We have webinars from E&M coding. We did a whole series. We did even a podcast type format with Kathy where we did
on the E&M,
on a new E&M guidelines, and we had about half a dozen E&M guideline webinars on medical necessity, CCI. We most recently, and I thought it was a lot of fun, was social determinants and how social determinants are playing a factor in reimbursement today. And that's not on our slide today, but social determinants are going to be a big factor. They're a big factor now, but they're going to be even bigger going forward, especially in our climate.
I think those new E&M guidelines are actually much easier. Once you understand them, they look kind of complex when you first read them, but once you really understand them, I mean, they're really easy. So just trying to get the doctors, to kind of change their way of thinking. We taught them for so long, oh, you got to document 8 of these and 10 of those and 5 of those, and now it's just like, no, just tell us your thought process. That's all we need.
Right, exactly. And you still need history and exam. You still need to kind of do that. Relevant history and exam.
I like that.
Not note bloat or carryover from a previous visit. Or I've seen some EHRs where they'll have a default diagnosis code. I was like, what's going on here? So the EHR vendors think they're doing a favor for everyone. It's like, oh, well, here's your default diagnosis code. And that seems to be following every patient. I don't know if that's what you guys have seen, but that's been one of the common
clone
problems.
notes are another thing that are a big no-no.
You mentioned preventative denials. What is your rationale coming up with what do you tackle first?
What do you tackle?
Yeah, I mean, that's a great question because you definitely don't want to just throw everything in there at once. I'd just say start slowly and work backwards. If you already have a good denials management process, you kind of look at, okay, well, what are we checking things at charge entry? Are we thinking, are we checking things at that encounter level and work that way? I think the most pushback you're going to receive is the point of care type of proactive approach because as we've stated, physicians can definitely push back on that because they're like, I just want to see patients. They don't see themselves as coding. But what they have to understand is, what you're doing is being translated to a code, and that's what the insurance companies understand. So, to answer your question, I would just take a slow approach working backwards. If you already have a good denials management process, okay, what's the next step? Move back. So, okay, what can we do to improve things at the next level up?
But would you recommend technical denial, medical necessity, authorization, or just buckshot approach?
I would probably analyze your denials and see where you're getting the most. If a lot of it's coming from the registration process. It's been a while since I worked in a physician practice because I've been in the consulting world for a while. But when I was in there, I would say 50% of our denials came from the registration, some kind of mistake in the registration. So they weren't really coding denials, and then so that was a big thing. And then there was I think coding was maybe 10 or 15% of the denials. That doesn't mean that just because you get paid for something doesn't mean you did it right too, especially on the coding world. And so you still have to do your auditing and your due diligence there. We used to tell that to doctors all the time, just because you got paid doesn't mean you get to keep it. So so you want to make sure that your coding is correct, even if you're getting paid for it or not. But you do want to look at the denials as well. But I see where your denials coming in because of lack of pre-authorization. If that's your problem, then that's where I would focus my time. I would probably take that type of an approach on it. Mm-hmm. But I find a lot of it's coming from the front end versus the back end, honestly.
Mm-hmm. All right.
The denials, actual denials. And then some of the denials, you're never going to get 100% no denials, or 0% denials, because just as they were talking about yesterday, the insurance companies are going to deny things just because they can, and because you can have a totally clean claim, coded accurately, documentation supports everything in it, but it was denied, and you look at it and you go, why? And so you just resubmit it, and then it magically gets paid. It literally makes no sense why that claim was denied. So always resubmit your claim, your denials. And I would take a look at them, make sure it is clean, and then just resubmit it. It's a mystery. I don't know. I worked with a consultant many years ago, and he used to work for a major insurance company, and this was back in the late 90s, so it wasn't recent. And when he was a manager there, and he was told at the beginning of the day, okay, I want you guys to deny 20% of your claims. So he literally walked around. This is why he didn't work there anymore. He had to walk around and tell each one of his adjudication people, I need you to deny 20% today. You need to deny 20% today. And I said, really? You mean that really happens? Because I just thought it was a rumor or a myth, you know, urban legend. But he said, yeah, no, they actually do that. He said, I couldn't sleep at night. I had to quit, you know. So, but yeah, I don't know if that still happens today. Like I said, that was in the late 90s. But my guess, after seeing some of the denials that I've seen, that, yeah, they still do that. I don't know that for a fact, but I always, like I said, I thought it was urban legend until I met someone who told me that they actually do that. Yeah.
That's a real thing. And also, one of the things we have not talked about is some of the regulations and waivers that came down with the public health emergency with COVID. And
now they're auditing all of that. Those telehealth, make sure you're doing them right.
They're going back and auditing all that. And I know from a real life experience, because my wife and I had COVID last year toward the end of October, 1st of November. And I'm still fighting those claims from a patient standpoint. I mean, I'm the benefactor, right? And so I'm calling, and I was very mild, but she had some things that were very, affected cardiovascular issues, respiratory issues, and I'm still calling all of the practices, the radiologist, everybody that was involved, to instruct them on how to process it. And they're saying, oh, we processed it the way you told us. At first they're amazed that someone's calling them and telling them how to code things. But then, they process it. Then I'm calling Blue Cross Blue Shield, and they're like, oh yeah, we received this, and we're going to reprocess it. So it's just a matter of, like Kathy said, you sometimes just have to resubmit it with no changes whatsoever, and it will get paid. And finally, I think all but one claim has been paid because it was just being diligent. And that's me as the benefactor being diligent. The practice wasn't being diligent. They were like, oh, they put this toward your deductible. You're supposed to pay this. I went, no, I'm not supposed to pay this. There's cost sharing. There's all those rules that need to be applied. And those are things you need to make sure that you can adjust on the fly, how agile you can be in there.
We're over our time.
Yeah.
So
We always go over our time. So
thank you. Thanks, everyone.
yeah, thanks, everyone.